So for some of you, this talk will talk about perhaps some of your clients, or if you're in the healthcare industry, is for an insurance purpose, your members. If you're in medicine as a provider, your patients. For others, it'll actually be talking about you and what is going to happen in the future with AI and how that's going to affect your health. So I guess I've got another minute to actually start, but that's setting the stage for this. So some of this will hit close to home, I hope. So since they closed the door, that tells me that it's probably on the hour. So, AIMD, virtual health assistants in the future of patient care. Are we ready for that yet? Are we thinking that this is a little bit too far out there? Well, I've been a physician now since before the earth cooled. And to put it into perspective, I watched Neil Armstrong walk on the moon live. There was probably a 10-second delay, but it was pretty close to live. And there's a couple of folks in here that can remember that day because we were actually old enough to remember it. Many of you aren't. So I got involved with this about 3.5 years ago when I wrote an article on using virtual assistant technology to improve outcomes and adherence. And how did that happen? I've been writing articles every month for the last 17 years on medical technologies, breakthroughs into medical technology, and the column's called Tomorrow's Medicine. It's kind of a play on my name, Tom Morrow, and it's also talking about what we can expect tomorrow in our medical care. And many of the articles are about some of the just incredible medications that have come out. During my lifetime, we've seen the transformation of medical care from, well, to put it into perspective, I didn't have a CT scan or an MRI at the hospital where I trained. They didn't exist then. And now they're on every street corner. The biologic drugs back when I was in medical school were horse serum and blood products from humans. And that was it. Now we're talking about all these advanced biologics that are made by organisms. And I spent 8 years working for one of the big biotech companies where we took DNA out of one organism, the human, and put it into another organism, a CHO cell or a bacteria. And we create medications with with that DNA. And those are the most rapidly growing portions of our medical delivery, or our care delivery armamentarium. Robots didn't exist, and I had the unfortunate but fortunate opportunity to experience one of those a couple of years ago when I had my heart operated on for a bad mitral valve, where I went in on a Thursday morning, went straight from a hotel to the OR. On Saturday, I was told I could go home. And they'd stopped my heart, put me on a bypass machine, opened the heart. This isn't the typical bypass. That's on the outside of the heart. This is inside the heart. They fixed the mitral valve and shrunk it and took out some areas that had deteriorated, probably from some genetic thing, because everything's genetic, and fixed it. And in 2 days, I'm able to go home. And my incisions are like little scratches from a blackberry bush. And we've watched just remarkable endoscopic procedures that have been able to be done for just a number of things. And now we're starting to get into devices that are just amazingly complicated, and we're using neurostimulators. And there's actually an artificial eye now where the electronics are implanted on the back of the retina, and they stimulate the nerves directly. And the camera that's the eyeball is sitting on a pair of glasses, and we're giving blind people the ability to see. Not very sophisticated. It's measured in pixels, not billions of pixels. But that's where we are with technology. One of the things we're starting to look at also is the use of software and all this AI stuff that's coming out. And we're starting to get some things approved by the FDA. some of the approaches that we're using won't necessarily need FDA approval, and the apps are one portion of that. So we're going to reshape healthcare with computer technology. We already have started to, and it's going to advance. So let me give you a concept. Well-being. What is health? Well-being is the presence of health, not just the absence of disease. Because you can have an illness and still have good well-being. Well-being is, I call it a precious and fleeting gift, because it's fragile. And there's a whole lot of things that can take that away very quickly. And I'm going to ask you a question about that in a second. But well-being is, a lot of it has to do with healthy behavior. And it encompasses a lot of things, from genetics to education to socioeconomic factors, cultural influences, interpersonal determinants, age, all kinds of things come into play with well-being. So what is the absence of that? And what ends up happening to every one of us? And last time I checked, everyone dies. Kind of a sad thing to talk about, but the reality is that I don't know of anybody that lives forever. And I'm going to ask you this question. Have you ever thought about your upcoming death? Will you choose the way you die? Some people do. Unfortunately, they do it at their own hands. But the majority of us choose it through our habits, through our behavior, and through all those little things that we do. How are you going to change that so that you can affect the way you die? Because we're all going to die, let's face it. There was a senator from South Carolina who was in his 90s, and he said that he wanted to die at the hands of an angry husband. And I thought that was an interesting way to put it. He was well into his life in his 90s, and I thought that was kind of a nice way. But the reality is most of us are going to die that way. But another question I like to ask is, how would you like some help to delay your death? And to not only delay death, but delay illness and delay the non-well-being that oftentimes accompanies the end of life. So, question. What do all these contributors of death have in common? Smoking, high blood pressure, excess weight, inadequate physical activity, high blood sugar, LDL, salt, all these things. Go ahead, answer. Somebody put their hand up. They're all manageable, and they're all modifiable. And yet, these are the number of deaths that are caused or contributed to significantly by all of these. And many of us have these things in our lifestyle. And many of you don't. But the fact is right now, we've got 10,000 people per day retired or hitting Medicare age. 1 in 9 of the elderly, and up to 44% when you hit 75 and older, develop Alzheimer's. And we know we can prevent that, or at least delay it significantly. We have roughly 90 million people right now with pre-diabetes, and another 20-some million. Altogether, about 125 million people in this country either have pre-diabetes or diabetes. When I was in medical school, that wasn't a very common disease. It wasn't. Now, 1 in 3 are predicted to have that within my lifetime. How are we going to take care of that? Because we're also seeing what's predicted to be a 90,000 too few physician population by 2025. Think of that. The typical medical school graduates 100 to 200 people, and we're predicted to have 90,000 too few. There's no way to catch that number. And that number is less than it was predicted to be a couple of years ago, because now they're factoring in all these minute clinics and the nurse practitioners and all these other ancillary providers. And still, we're going to be seeing a huge shortage of professionals. And not just physicians, we're talking nurses are going to be a shortage also. Part of that is because of the baby boomers. I'm one of them. I'm kind of in the middle of that group. 20 to 25% of all medical practitioners are in that group, and they're all looking forward to retirement. So they'll become patients at the same time they're leaving practice or they're leaving the profession. So we're facing just a tsunami of issues. Behaviors are critical to health outcomes, and we don't pay enough attention to them. We ignore them, and we as Americans think that there are no consequences to our behaviors. And it was interesting, I had a friend who was the head of HR for General Motors, and this was 20 or 30 years ago. He was at a meeting in England, and he was talking about health, and one of the Brits said, "You Yanks act like death is an option, the way you spend money on healthcare." And we do. Everything's acceptable and everything's affordable, except when it isn't. And that's what we're starting to see in some of these third world countries that used to be first world countries. And I visited a number of them along the Mediterranean Sea last year. And we're starting to see the disintegration of some of these societies because they have gone into debt because they're spending money they don't have. So we're no better, we're no different. And if we think that the consequences of our behavior are going to be somehow made up by some magic formula, it's not going to happen. I'm not going to try to be depressing though, because we've got ways to fix this. And Winston Churchill once said that Americans can always, always be counted on to do the right thing after they've tried everything else. And unfortunately, that's what we oftentimes do. So, what's a virtual agent? We've all seen them. Back a couple of decades ago, Hal over in the left corner, and Watson won Jeopardy. Siri is a virtual agent. Her video, anybody see that? A little racy, you know, got a little bit scary at times, but there was actually, I saw on the syllabus, there was a talk about virtual porn in the future, so I guess the movie wasn't that far off. And then Robin Cook. If you haven't read the book, it's a quick read, and it gets a little bit scary because it's describing precisely what we're going to actually be developing for medical care. A virtual assistant that's going to help us with our health care. So, just as a quick example.
Good morning, Richard. It's Sarah, your virtual health assistant. Are we still on for a 7 a.m. run?
Sounds great, Sarah. Thanks for the wake-up call.
Hello, Richard. Are you ready for me to activate your pedometer app for your run?
You bet, I'm ready to go.
Would you like me to play your usual music selection for your run today?
I think I'd like to listen to my workout playlist instead.
Okay, I've selected your workout playlist for today's run. Hello, Richard. You've requested that I remind you to weigh in, register your blood glucose reading, and take your diabetes medication.
All right. I've registered my blood glucose and taken my meds. Will you schedule my weigh-in reminder for tomorrow at 7:30?
Certainly. Your new weigh-in reminder has been set for tomorrow at 7:30 a.m. Hello, Richard. I've noticed that it's been a year since you had Dr. Anderson check your eyes and feet for diabetes-related complications. Would you like me to check your calendar and schedule an appointment?
Yeah, that'd be great.
I've checked with Dr. Anderson's office, and it looks like he has an opening on Tuesday, April 8th at 9 a.m. Would you like me to book the appointment?
Yes, please. Thanks, Sarah.
Hello, Richard. I've assembled an overview of this week's health statistics, including your blood glucose levels, weight, and distance ran. Would you like me to review it with you?
Thanks, Sarah. That'd be great.
As you can see, you're running much farther and faster than you were 4 weeks ago. Congratulations on a job well done. Also, you've gained enough points to waive the copay on your medication this month.
I appreciate the update. Talk to you soon.
Good night, Richard.
Night, Sarah.
mean, that's a depiction, but the reality is one of those is already out in the marketplace. It was created for multiple sclerosis patients, and it helps them to remember and tell them where to give their next injection. And that particular agent is for a drug that's used every day, and it's spread across numerous injection sites, and people just don't remember. It also helps, it can answer 10,000 questions. The key is it doesn't have the ability to answer, it has the ability to understand the difference in 10,000 questions. Think about that. I mean, I don't think I could answer that many about MS, and yet the agent does. And it also has the capability to do virtually everything that was done here, plus more. And that's with existing technology. So what is a VHA? It's a comprehensive system. It will attach and use the personal functions on your phone. It'll connect to all types of different data systems. It'll engage, and it doesn't matter what your health literacy is, because it will create the language in the level that you want it to be in, and perhaps even the language in a different language, such as Spanish or some of the other ones that are common in the United States. Empowers, and the big thing is it's all about you, because it's going to revolve around your needs and your constantly changing desires as it comes to healthcare. And there's a whole lot of psychology that has to be built into that, and we're starting to recognize that in medicine. We know that if we engage patients, they do a better job taking care of themselves, and there's no way on earth that I as a physician or any of the docs in the country or any of the nurses can take care of all of these people who are going to need us. You're going to need to take care of yourself, and you need to get engaged with your own healthcare. And if you're in the healthcare profession, you're going to need to do that for your patients. And we don't have good ways to do it. What I didn't say so far is I started and ran 5 health plans, 5 different HMOs. I also ran a disease management company where we had hundreds of nurses making outbound phone calls to patients with chronic illness, and we had several 100,000 patients that we were in charge of with diabetes, heart disease, COPD, asthma, a number of different illnesses. And it was like talking a dog out of a meat truck to get them to change behavior. Think about that. How hard would that be? That dog's going to come out when he darn well wants to, because his main goal is self, food. And what we don't recognize is most of our actions aren't conscious. We just do things because they're habit. We're taking a medication, but the other stuff is just the lifestyle issues. These are some of the reasons, and I'm not going to go through all these individually because this is just a small sprinkling of the different reasons that people don't do it. None of this is new. Somebody you may have recognized from 2,000 years ago, Hippocrates, said that people just didn't do the right thing. This isn't new, this is human nature. It goes back thousands of years. It was an interesting article that was a Cochrane Databases. They're a think tank that do analysis on a bunch of different healthcare issues. And what they did is look at interventions to enhance medication adherence. And this was specifically looking at medications, but the same thing could be said about any of the lifestyle issues that we partake in. Their conclusion were the current methods of improving medication adherence for chronic health problems are mostly complex and not very effective. And we've got a lot of things out there that health plans and your physician's office and others have tried. But the full benefits of treatment cannot be realized because of their complexity and their cost, because they're all enormously expensive. I ran a health care company, and we had hundreds of nurses who were doing those calls at a disease management company, the same thing. And the fact is that the loaded cost of those calls were close to $100 a call, because they were long calls. How do you do that once you have 120 million people with diabetes alone? And 1 out of every 3 people age 75 and older will have Alzheimer's, both of which are preventable. So why are we treating this, or are we planning on treating it with a shortage of physicians when we can actually prevent a lot of this stuff? So why don't the current approaches work? What are the factors of engagement? How do we actually engage people? Here's a couple. The quality of the patient-provider relationship, the provider attitude and communication style, reimbursement or lack thereof, disease management supports, the follow-up and continuity of care, evaluation of adherence, and there's a whole bunch of processes to do that. Amount of time spent with the patient, and I had 8 minutes last time, by the way. I'm sorry. Patients' competing priorities, socioeconomic status, transportation, social support, availability and quality of the medical care that's available to them, ability to afford the health care services, symptom severity, disease severity, condition-related disability, rate of progression, prognosis, commonly associated comorbidities such as depression, substance abuse, complexity of the regimen, the dosing, the pill burden, the dosing interval, the restrictions of dietary and other drugs, the duration, short-term versus long-term. How about pill fatigue for those with HIV? Immediacy of beneficial effects, side effects, ability to follow instructions, knowledge of and skill with self-directed health-related behaviors, trust in the provider and the medical system, degree of family dysfunction and or chaotic lifestyle. Anybody have a chaotic lifestyle? Yeah. Education, literacy, age, lifespan factors, personal and cultural beliefs regarding health and disease, motivation, perceived need for treatment, confidence, acceptance and understanding of the disease, and ability to engage in illness-related behaviors, perceptions, attitudes, expectations, hopelessness, acceptance, fear of dependence, frustration, anxiety, disease, burden, neurocognitive function or dysfunction, psychological status. How many of you, personally or professionally, are managing all of these factors? How many of you could possibly manage all of these factors? One-on-one I can. We've got examples of more complex behaviors that we can get people to do. My son-in-law flew F-15s. Pretty complex machine. He was able to do it. I didn't really think he was that bright, actually. I didn't tell his wife that, my daughter. But, you know, he was acceptable for my daughter. We have a lot of jokes about that. But he was trained to fly that. One of the most, well, it isn't now, but at that point it was the most sophisticated airplane on Earth. We've got professional athletes that do things that we just wonder how they can do it. Go to Cirque du Soleil someday. How do they do that? They're capable of doing it. Just bricklayers and electricians, they have apprenticeships that go through and teach them how to do skilled work. We have more coaching and more time spent teaching a 6-year-old how to hit a ball with a bat than the typical person gets to treat his chronic, life-threatening illness. Think about that. I used to give him a prescription and a whole list of things to do and say, come back in 6 weeks. And we actually expected them to do it. And then Hippocrates hit me in the face one day and said, they haven't done it for me either. Don't get that upset about it. Just get over it, Tom. You got to figure out another way. And so we invented all these things. And more importantly than just managing these, how can you manage them effectively? We don't have the people, we don't have the time, we don't have the expertise, we don't have the money. There's no resource available to do it to the level that we should. But we do it for the professional athletes, we do it for the pilots, we do it for all types of other professions. But when your profession is treating your illness, it's not done. And we end up with the consequences. So how do you engage with people? The old-fashioned office visit. It's been working for thousands of years. Phone calls, telemedicine, text messaging, apps, other texts, and even letters. The old-fashioned snail mail. The effectiveness goes down as you go down this list. The cost goes up as you go up the list. What are the commonalities of the ones that seem to be the most effective? It's conversation. Think about that. Have you ever done anything important in your life that didn't revolve around a conversation? Other than stupid things. Yeah, I live in the Southeast, and you know that there's going to be a really interesting thing happening when somebody says, here, hold my beer. That's when the brain doesn't engage, just hormones typically do. And we have things happening, but the conversation was pretty simple at that point, you know. So let's think about important things. When was the last time you really had an in-depth conversation with a healthcare professional? Or if you're a healthcare professional, when did you actually have the time to spend with a patient that you knew he needed and he would benefit, he or she would benefit from? And what's the reality of the world that you're living in now with 8 to 10 minute visits? And the last time I was in, the guy was talking to me while he was touching on his pad, because the most important thing in that transaction was the recording of it for the bill. And he knew I was a physician. He would give me professional courtesy. He actually put his tablet down once and looked at me. I felt so privileged. So these are categories of engagement or adherence approaches, and we've been using a lot of these. And this is excluding. These are technology processes. The EHRs, the electronic prescribing, the telemedicine, and telemonitoring, all these apps and gizmos and gadgets, these wearables, I'm going to throw into part of that. The packaging, we've got blister caps, smart pills, smart bottles. We even have the smart pill that you take it and it has an RDIF in it, and as soon as it hits the stomach acid, it emits a signal. They work quite well. Cloud-based. Games, social platforms, text messaging, and the typical text message. Tom, did you take your medicine? Yes, and I'm having a stroke. Thank you. I'll remind you tomorrow. Doesn't even tell me it's going to send flowers. But that's what I'm going to need. Health plans have financial incentives, and those are big. And there's all kinds of pay-for-performance activities that are happening right now, and they've been happening for years, but they're kind of being built on the whole Accountable Care Act. Predictive modeling, risk scoring, we've been doing that for a number of years now. It's getting much more sophisticated. We can actually start to predict people who are going to stop their medication now, and it's a variety of factors we take in, including all the self-reported stuff. We've got disease management, case management, medication therapy management processes, and all of these work. Problem is that, again, those that are most effective are very costly. And the ones that are technology-driven and don't rely on a lot of people aren't very effective, or they're niche. And then we have AI and natural language. And that's where Sarah comes in, where you can talk to her, or him, and she can talk to you. She can tell you what you need to do, as well as advise you and cajole you, joke with you. In fact, if you ask her what her favorite actor is, it's Samantha and her. And we build personality into these. The World Health definition of adherence is the extent to which a person's behavior, which includes taking medication, following a diet, and or executing lifestyle changes, corresponds with agreed upon recommendations. And that's where the problem lies. When I hand out that piece of paper with the prescription and all these lifestyle changes, they haven't agreed to any of that. It's been thrust upon them. And unfortunately, that's what we do in the medical profession. We tell them what they should do, but they don't necessarily accept the fact and do it. And there's a whole lot of reasons for that. If you want to get a good example of what some of the reasons are, take care of a 2-year-old. How many of you have kids who are taking care of a 2-year-old? Do they do what you want them to do? No. And their only word they really concentrate on is no. I've got almost 12 grandkids that almost is due in a month and a half. And the youngest, other than the almost, is 18 months. And he's learning no. And the terrible twos actually start at 18 months and they last till 30. But that's dealing with the same thing that people deal with when they have an illness. They don't want to. They don't want to accept it. They don't want to listen. They don't want to change their lifestyle because it's convenient to be in the moment and do what you've done in the past. Behavior change is a process that unfolds over time through a sequence of changes which are pretty predictable. And it goes from pre-contemplation. Have you ever considered stopping smoking? Say no. That's pre-contemplation. They're not even thinking about it. They haven't even considered it, or they don't want to. All the way down to through contemplation, preparation, action, maintenance, and then finally, I don't even need to be reminded it's a behavior I have already fulfilled, whatever that behavior is. It could be a negative behavior, stopping something. But they don't need any help at that point. Think about these. It's the same kind of thing you had to do when you got on your knee and proposed to your fiance. Or when you went to buy a new car. You didn't really want to. You kind of wanted to, but you didn't want the expense. Or getting a new apartment. These are just how we cope as humans. The health belief model is that people's actions are dependent upon their feelings of susceptibility, seriousness, benefits, and barriers to behavior, triggers to action, and conviction that the action will produce the expected outcome. It's interesting because many of the drugs we give people have side effects that don't produce the expected outcome. I worked for a drug company that was the largest biotech company in the United States and produced primarily cancer drugs. We didn't make people feel better. Hopefully we gave them some efficacy and killed their tumor. But the reality is nobody taking any of these drugs felt better after they took them. You've seen people with them. There's also a whole lot of unconscious determinants of behavior. This gentleman who's a friend of mine says that not every health decision is the result of a logical progression of thought. Hold my beer. We don't think about stuff, we just do it. In fact, we do it without thinking 90% of the time at least. And some of these determinants of health are so ingrained that we don't even recognize they're bad for us anymore. And some of them are based on advertising. Any of you in marketing, you know that we can change people's behavior by advertising a lot. And the poster child for that is, I lived in Atlanta for 20 years, Coca-Cola. They invented marketing. Good, bad, indifferent, whatever you feel about them. Everybody thinks they need a Coke because they've been told that 10,000 times by the time they're 5. And it makes them feel better. So it's self-reinforcing. I was driving through the Ecuadorian jungle and a Coke truck went by. I hadn't seen anybody for 80 miles. Yeah, they're everywhere. And they're exceptionally good at marketing. I'm not saying anything bad about the company. The fact is that we're influenced by all these subtle reminders to do things. And many of those reminders aren't good for us for long-term health purposes. In medicine, we always thought it was all about the relationship. And I still believe this is true. Because that relationship with another fosters healing, it helps information exchange. And a lot of these self-belief theories and health behavior models rely on the knowledge that this behavior that you're trying to change is actually beneficial for you. And you need to understand your disease process and what causes it to get worse and better. These relationships also respond to emotion. They manage the uncertainty when you're dealing with a health problem. They help with decision making and enables patient self-management. Not all relationships are equal though. If you use specific motivational interviewing processes in this, and this is a big approach that's been out there now for probably 20 years now. It was put into writing as a theory in 2009 by Miller and Olmec, but actually a little bit earlier than that. This is another version of it, that it's patient-centered, develops rapport, allows patients to remain in control. A lot of open-ended questions, empathy, affirmations, reflections, summaries. Sounds like teaching a kid how to play ball, doesn't it? A lot of pats on the back. Yeah, attaboy. Hey, move it up a little bit, hit a level out, get the bat in a better direction. It's no different than most of our other activities where we have accomplished behavior change to a sophisticated endpoint. What about apps? Well, there's probably 100,000 of them out there by the time this talk's over. I mean, they're coming out like crazy. And there's a whole lot of data on them, and there was an interesting article that IMS put out last year concerning them. But here's the deal. How big is the iPhone 7 going to be? I mean, how many apps are you going to put on there? Is it going to be like a walking stick? And they're not necessarily connected. She can have an app for everything. And the fact is most of the apps that are out there are basically electronic diaries and reminder systems. Most non-adherence is not because I forgot that I drank too much last night. I forgot my pill. It's, I don't feel like I need it. I don't want to have to take it. I don't like the way it makes me feel. I can't afford it. I can't even get transportation to pick it up. Whatever the reason is, and there are thousands, an app isn't going to fix them all. So what's a virtual assistant able to do? Combines conversation, high touch, and the big thing is cost. There's nothing this thing can do that a nurse can't, or a doctor. And, my family got a little spoiled. I was the doc in the box. The box was called our house, and I still get called. What I've done, though, is I've kind of gotten out of parts of that. I've nudged it aside. I bought my one daughter-in-law a whole kit of strep tests, so I don't have to try to diagnose it over the phone anymore. Hey, Tara, did you do the strep test? Yep, it's negative. Well, then you don't have strep. Call me in the morning. Take a bottle of aspirin and call me in the morning. No, I don't actually say that. But that's what I was thinking occasionally when I was in practice. Just get out of my face. Why do you need some more advice? I've taught you this so many times. You just need some reassurance. We can provide those with a virtual app. They also combine the ability to understand natural or everyday language. Do I need an umbrella today? Did I say anything about the weather? No. But all of you understood precisely what my question was. That's natural language processing. And a typical 3 or 4-year-old can answer that question. But until 2 years ago, Google, if you put that question in, took you to an umbrella store. Literally, I checked it. It started changing about 18 months ago. Now they get the idea and they take you to a weather channel place, So that's key. The other is characterize human intent, because it can understand what the meaning of your statement or question is, and then provide the resolution to it. And it also facilitates this in a highly contextual manner. And that's important, because these things are being programmed to understand you as well as understand your situation and your past communication with them and the data that's already in the perhaps EHR or your claims record. And they'll know you. So when I go to the Aetna website, which I'm an Aetna member, and I would put in, I'd like to look up my son's claims, it would say, Tom, you have 2 sons. Now, luckily, they're not on my dole anymore. They're all adults. But the fact is that if they were still dependents of mine, it would know that I have 2 children that are boys and 2 that are girls, and that I would have to give some more clarification in order for it to answer that question. And that's the level that we're at with these. It's not that they're operating in a vacuum. They exist in the real world attached to databases. The other thing is, when it comes to patient engagement, it's really a negotiation. Because we don't make changes quickly. And I'll throw up another slide in a minute, but the fact is that I've got to negotiate with patients and with clients, with pretty much anything in healthcare. It's a back and forth. It's a conversation that comes to an agreed upon endpoint. And that's when we start getting progress. So I'll ask you the question again. Why don't people take care of themselves? Well, here's the answer. You don't know until you ask them. And sometimes it takes a long time to get there. So, about 3 years ago, I went home. My father-in-law had mesothelioma. You've all seen the advertisements by the attorneys. There's a big, pot of money for all those patients, because mesothelioma is a human-created disease. It does not occur in nature. It's caused by asbestos. That's the only way to get mesothelioma, pretty much. It does not, I don't know that there's any evidence that it occurs in nature unless you live in an area with a high asbestos content because of the minerals around your area. He developed mesothelioma. The average lifespan after diagnosis is about a year and 2 months. He was a year into that, and we went to visit him at Christmas time, and he didn't want to talk about it. We were putting together a 10,000-piece puzzle. It was his whole table. And we sat there for 3 hours, his daughter, my wife, and he, putting that thing together until he finally was willing to talk about what I asked you earlier. The end of life, cause of death, and when. And I said, Dad, do you know what the numbers are for this disease? And I didn't want him to mention it because he didn't ever talk about this, despite the fact he'd been in chemotherapy for the last year. His comment was, the doc said, I probably won't live 10 years. To which I thought, that's a pretty good statistic given you're 82. You know, I could say that about pretty much any 82-year-old who was doing a marathon today. And I said, Dad, do you want me to tell you the numbers? And we continued to put the puzzle together until he finally responded. He said, what do you think I should do? And I told him that the average person lives roughly 15 months. This was Christmas. He died in March. He hadn't even produced a will. He was still in denial. His doctor gave him the idea that he was going to live in less than 10 years. He was right, technically. But that wasn't what he actually needed. He needed some more in-depth knowledge. He was in denial. His dad, to put it into perspective, lived to be 99 and a half. So he was expecting another 17 years. And his mother lived to be 92 or something like that. And his uncle, his brother is right now 98. So, long-lived family. And he just didn't think it was going to hit him. And he didn't even prepare for it. So, what I learned there was that at the core of every successful conversation lies the free flow of relevant information. And he really wasn't freely flowing either direction. He needed that. Most people with even minor illnesses need that. Because the free flow of communication helps us with all these common chronic diseases that are going to kill you a long time from now, but they're still in need of care now. We need that in order to fulfill this model. This is a VHA Fogg out of Stanford, has summarized all those 80 theories, which are in a 400-page textbook of behavior change, into one little equation. Behavior is equal to motivation, ability, and trigger. And they all have to happen at the same time. So what's motivation? I can't motivate you. I can produce things to help you motivate yourself. Conversation helps that. I can give you goals. I can give you advice. I can give you knowledge. And theoretically, we can get people motivated. And we know we can. It's been proven over decades. But your ability to change is highly dependent on how big that change is. If I tell a 400-pounder he needs to lose 280 pounds and start exercising at least 10,000 steps a day, the likelihood of that happening is pretty low. In fact, I'd be more than willing to bet my next 5 years' paycheck on the fact that he wouldn't do it. So that's the ability. It has to be broken down into individual pieces that are small enough to actually do. And then you need a trigger. We're triggered like this all the time. My daughter, who I visited this week with her 3 kids, the same one who used to fly F-15s, he now works for a nuclear power plant. So he's still in the big bang stage of life. They had all kinds of things around their house to help motivate their kids and do this. We do this very well with children. Why can't we do it with people with disease? All 120 million people with prediabetes, diabetes. Because we don't have the time to do it, or we just haven't decided to use the technology. We know that the average person with an illness will spend several hours at most in the presence of a professional of medicine, of any discipline. And they'll spend 5,000 hours, waking hours, each year alone or with people who aren't in that profession, making decisions that affect their illness or their condition or their disease. And that's the other 5,000 hours this article in the New England Journal wrote about. And the fact that we need processes that amount to basically automated hovering. And we talk about these helicopter parents and the hovering parents and stuff, that that's not a good thing. But the fact is we need that for people with chronic illness. Because they're not willing or capable necessarily, because of their mental attitude and resistance, ambivalence, whatever it might be, of doing this on a regular basis without an enormous amount of one-on-one. And an agent will do that. We already have evidence that these things are working. These are in the academic literature. They've been shown to improve exercise. They've been trained to do all kinds of things, and I'll give you some other outcomes in a moment. They'll know the clinical guidelines. They'll be able to handle adverse events. They'll operate within the medical legal boundaries of whatever institution or organization you work within, whether it be a hospital, a pharmacy, a drug company, physician's office. They'll reflect your branding. They'll get smarter over time. That's the key thing, because these things aren't static. They're constantly going to be learning. And they can ask questions. How would you like to be able to ask the patients in your practice or your institution or whatever organization you work for? What are the biggest issues you face because of your condition? If you had access to the world's expert on your condition, what would you ask him or her? Or any other question you want to ask. Just think about the information you'd get back. And this self-reported data is going to be key for rebuilding our healthcare system in the future. Because effectively, I've never had a patient where I didn't ask them, how are you feeling? I couldn't get everything from some biometric measurement, a lab test, x-ray, or something else. I had to ask them questions. And self-reported data is incredibly important. And we're not taking advantage of it. Clinical results, one of these showed improvement of readmissions by 30%. Interesting thing is that 74% in this one study, and this was done up by Tim Bickmore up in Boston, 74% of the people preferred an agent over a human. And there's other evidence that shows this. We like gizmos. How many of you have used the teller at a bank recently? Very few. You always use the ATM or online. I fly a lot. I go to Atlanta Airport, and I can't remember the last time I actually paid an attendant. It's all automated. Many of our day-to-day functions are now automated. All of them used to be done by humans. So we actually prefer it in many cases. And this is no different. This was an interesting study. These were people who had psychosis, dealing with an agent, and they preferred it, and they actually became more adherent to their medication by having an agent, a computer, talk to them instead of a person. I thought that was kind of an interesting study because, these are folks who hear voices. And I'm not making fun of them. That's how they are. And an agent was doing a better job than people, which was kind of an interesting study. This market, now this isn't talking about just the healthcare market, but the total market with these virtual assistants, generically, and that includes all the automated things on the web and the live chats, which are actually chat bots and stuff. We're looking at $3 billion in 5 years. Medicine's a small portion of this, but this isn't something that's a small startup industry. This is already a maturing industry. It just hasn't been done with healthcare to any great extent. These are the main companies in this space. There aren't very many of them. And they have all types of different focus. I've looked at their products, and there's actually very little competition amongst them because they're all focused on different sectors. IBM I didn't put there because they're really not looking at direct-to-patient activities right now, from what I can gather from their publicity. What they're doing is decision support for physicians, but Watson certainly is in this category, but they're looking to help physicians make decisions, not individual patients. But these other companies are kind of in this space. I happen to work for one of them. And the reason I work for them is because I had a younger brother who died from non-adherence. I went to his daughter's graduation. And I started looking at this in great detail. This is after starting health plans and running a disease management company and working in medicine for 30 years. I realized that if he had one of these sitting in his pocket, that was telling Dave, "You stupid," and I could use some expressions there because I'm still mad at him. Pretty bad to be mad at a dead person. But the fact is it wouldn't have taken much to get him to take his statin and aspirin. And he'd still be alive today. He was still working as a cop in Pittsburgh. And he was impervious to that. And he actually dealt with non-adherence. He said he used a taser, and it worked quite well. I'm hoping we don't have to use that level of technology, because every one of you, unless you're really from another planet, has one of these in his pocket right now. And there's no reason we shouldn't, can't, and won't use these in the future to help patients. And I see these being in everybody's pocket. Now, we've just been talking about this being kind of a nurse. There's no reason this won't get into direct medical care eventually. The algorithms that produce diagnosis have been written down. They've been established for decades. We use the Washington Manual, which every intern carried in his pocket on his white coat. We can automate those in these. We need to get FDA approval for that level of sophistication, but the fact is that the technology can do it easily right now. And we'll eventually get there. We'll have automated things like this that are actually doing surgery within my lifetime. We're going to be going into this virtual reality where it's real. It's not virtual. Very quickly. Because it's the culmination of the ability to understand speech, the ability to do enormous processing in very short periods of time, and the ability to influence behavior, as well as just fitting the entire book of knowledge that we have on all medical conditions through the cloud, accessible with one of these. And that's where these virtual agents are headed. So questions? Comments? Are you scared? Yeah. Oh, well, right now it's expected to be the pharmaceutical companies, the pharmacies, the health plans, large integrated systems, PBMs, specialty pharmacies, anybody that has their hand in something that is made better by patient adherence. And think about it. Health plans are at risk, and they pass that risk on, and that's the big part of the Affordable Care Act, is passing that risk on to the hospitals and the providers. So anybody in that risk model is going to be looking at this because it's going to reduce their costs. Because ultimately, a health patient doesn't need a physician. And we need to get this into the hands of the pre-ill. And there's a thing in medicine. You can be healthy, you can be early ill, and you can be late ill. And there's obviously it's a spectrum. But the fact is we don't spend anything on the early sick. And that's where this has to go eventually. There was another question over here. I'm sorry.
What's the role of educating the patient in all of this? I mean, has there been any research done on whether you get better adherence through these kinds of programs, if there's any education?
Even apps will do that. But yes, I mean, think about it. Any professional in any industry, whether it be blue collar, white collar, any of you, you've had education to get you your level of sophistication for your job. And yet we don't produce that education for the ill patient. We tell them to go read about it. And then what do they read about? Can you control what they access on the internet? You Google any disease and the top paid ads are for vitamins and supplements and all this junk that have perhaps no evidence whatsoever that they're effective. And we're not screening that for people. And we need to. Because the amount of information out there is just too massive for most people with an illness. And the quality of it is all over the place. So these agents will have the equivalent of a lesson plan, basically. But also, it'll be dabbled to them slowly, because you don't want to have a whole lot of this. You're not going to send a factory worker who just was diagnosed with diabetes into a 6-week training program for his diabetes. It's not going to happen. It has to be slow and consistent and constantly rewarding him for good behavior. But education is a key component. There was, I'm sorry, lady first, then you.
Hi. It's actually a two-part of question. So one is for those VHA, does it takes time to train them to be kind of adapt to your lifestyle question, to understand like natural language?
Yes.
The second question is, once you become very sophisticated, smart, what's the role of the doctor?
Okay, so the agent, there's one agent that actually is on the marketplace. It's for MS. You can go to the Apple store and download it. It can answer 10,000 questions right off the shelf. A year from now, who knows? It could be 20 or 30 or 40,000. And it'll be doing lots of other things. It depends on what the sponsor wants to do with it. But yeah, they will continuously learn. The doctor, I don't know. I don't want to know which questions he asks. I just want to know how he's doing. So for me, for an MS patient, as long as they're not having relapses, they're not having any deterioration in their disability, as long as they're taking their medication, I'm happy. For somebody with rheumatoid arthritis, I'd like to know how their swollen and tender joints are doing, because that's the measure for that. For somebody with diabetes, I'd like to know that everything's copacetic. Their sugars are fine, their A1C is fine, they've had their eyeballs checked, they know how to take care of their feet, all these things that we have in our guidelines. But I don't want every blood sugar number sent over to my office. I can't handle that. These things can sort through that stuff and produce a report. And that's what I want. I want a dashboard. But more importantly, I want a dashboard on people who do listen. So not accessing one of these things on a regular basis is just as important to me as knowing that they're well. Because if they're not accessing it, they've fallen off the wagon from my perspective. So we're going to be building that type of intelligence into these over time. Eventually, they will augment the doc. Right now, they're just supplying data and helping the patient cope with his day-to-day needs. The only difference is FDA approval and regulatory guidance. The capabilities are there. We can build them tomorrow. There was a question here. I'm sorry.
Do you regard the big tech companies, Apple and Google in particular, as friends or foes in this journey, particularly with respect to sort of this landscape of your competitors, but also in terms of access to the device and controlling what information will be allowed to pass to the patient?
You talking about a conspiracy theory kind of thing, or are they
just the
I mean, Apple with their health, I forget the term they use, their
health kit.
Yeah, health kit. They're obviously heading in this direction, but they're producing the technology, the hardware to run this. They're looking for people to produce the software. This is software and processes and systems in place. But the device has to be a smartphone or some sort of intelligent device, a tablet or a computer. It doesn't work on a flip phone. So they're interested in the hardware primarily, and they're opening up their access to the health kit to some of these things. Google, I don't know where they stand on it.
I guess I just see Siri and Cortana and Google Now all as voice-activated agents that are looking to aggregate entire life experiences, and to me, a VHA appears to be a subset of that.
It is. Well, obviously, I use Siri all the time, except last night when the whole circuit was overwhelmed by too many geeks in the area, and said, I'm sorry, I can't answer your question. So I got on a map, did the old-fashioned way. But yeah, any of those companies have access to natural language. And the technology, that ability is sitting out there. These just happen to be the companies that I've been able to identify that are actually looking at direct patient interaction. But any of them could do it. It requires a focus, though. And it requires money, basically, and a sponsor, so to speak. And it's risky because you don't know if it's going to work. We don't have good evidence that this is going to work on the scale. We have lots of academic evidence that it works in small studies. Health information, well, first of all, you opt in to use it. And parts of it are going to be only residing on your phone. Others will be residing on other servers. but they have to be HIPAA compliant. I mean, we can't just have this hackable by anybody, and we're not going to be putting this blabbermouth. But the reality is I told you several things about myself today that I really don't care if you know. Most people aren't that concerned about HIPAA. It's crazy to think how serious we treat HIPAA when the average person really, they talk about their diseases on Facebook all the time. You know? So I'm not, you know, critical of HIPAA as much as I am that we think that that's such an important thing in our lives. But I just told you I had heart surgery a couple years ago. Who cares? I don't care who knows it. I'm on a thyroid pill too, by the way. I take a statin. Okay? That's it. I'm not going to tell you about anything else. There are a couple things I don't want to tell you about. Perhaps. Or perhaps not. But the fact is there's only certain things about our lives that we really are careful about. I wouldn't come up here and tell most people I was on an HIV drug. That's probably a little bit more sensitive. And I probably wouldn't tell people that I was on a schizophrenia drug because there's a social stigmata attached to it. But the fact is for most things, hey, people are talking in the waiting room all the time about, hey, I'm on that drug too. You have, and for most people, that's not the biggest issue. The biggest issue is they need help. And they're reaching out on the internet to chat rooms, and they don't have any idea what the quality of that help is. And I would prefer to give them something HIPAA compliant, certainly, that gives them screening information that's consistent and giving them the proper information and advice than what they're able to get through a vitamin store that may be bringing stuff from China that's mixed with other junk. We don't have a clue what quality of healthcare is being delivered. And if I'm at a health plan, I want to know that. If I'm at a specialty pharmacy, I want to control that information and give them the right data and the right information. If I'm at any sort of a professional level, I want to make sure that I'm giving those patients the right thing. And there's no way to do that by handing them a piece of paper and telling them to research it on their own. Other questions?
Well, when you provide a professional advice, you're licensed to do so because you've trained through medical school and you've gone through your residency and such. So when you develop this app that's potentially would be providing an advice such as, well, your glycemia level today is 7.2. Please take such and such dose of insulin. How do you make sure that this is even, feasible in terms of FDA approval, for example?
Well, okay. There's a line in the sand the FDA is drawn, and that line is as long as it's doing reminders, education, simple things, then they're under their purview, but they're exempt devices. Once it gets to yes, you need to take 42 units of insulin today instead of 38. That's FDA. That's going to be regulated, and they need FDA approval. These devices are just right now are just short of that. We have glucometers that are smart glucometers. Livongo is a company that makes one of them, and it's actually giving you advice. And we're starting to get some of these devices that are telling people what to do. That's different, but they'll eventually cross. They'll be blended together quickly.
So it's being approved as a device right now?
This is by the FDA considered a device, but it meets their exempt status. Because it's not making a judgment, it's not telling you to do something that your physician didn't tell you to do. It's just short of advising you on changing things. And it's not going to make a diagnosis. Could they? They could do them tomorrow. I mean, literally, just the programming time. Because I can program into it how to diagnose most things. How do I diagnose? I use an algorithm. Some of them are very simple algorithms. Some of them are sophisticated, but they're all up here. The processing power of these things is much better than most physicians. We could easily build them in, but that crosses the line. And at that point, we go after FDA approval. But right now, what they're built for right now is considered exempt by the FDA.
Sorry, we can't have any more questions because we need the room for the 12:30 section, but thank you.